mute yourselves if you'd like to ask a question as well. So great. Okay, so it is 9 a.m. and we want to respect all of your guys' time as well. So I think we'll go ahead and get started. Let me just make sure everything's going great. All right. So welcome everyone to the UBC Mini Med School lecture series for 2023-2024. Thank you all for your time in joining us this morning, and I'm very excited to be presenting on this topic for you all. So our topic today is on Ozempic and other GLP-1 agonists. And if that didn't make sense to you guys just now, hopefully it will all be clear by the end of the lecture. But as you may know, Ozempic is something that has been in the news a lot lately that you may have heard of. I don't want to give too much away yet about exactly what it is, but trust me, we will spend lots of time today talking about it. So we are going to get into that. Here's where we currently are in the Mini Med School lecture series. We only have 2 left, today and next week. However, all of the previous lectures are currently available on YouTube, and that can be accessed through Dr. Jane Gair's website. And I have a link at the end of the lecture as well to direct you all there. And so we've done this a few times now, but just to reintroduce ourselves for those of you joining us for the first time, my name is Michael Smith. I am a second-year med student from UBC's Island Medical Program here in Victoria. My colleague is Derek Anderson, also a second-year med student from UBC's Vancouver Fraser Program, and he's joining us today as well. Our supervisor, Dr. Jane Gair, who you may all be familiar with, is also here, and together they will be helping to monitor the chat box if you have any questions or concerns during the lecture. So we are conducting the Mini Med School program as part of our UBC Schools program called Flex, where we get the opportunity to engage in scholarly and educational activities. You may have seen the QR code at the beginning, and that is for our research purposes to help improve this series of lectures for the future, as well as assessing its effectiveness in answering your questions. So if you're attending these lectures, I greatly encourage you to participate, as it really goes a long way to help our education as well. Now, before we get started, I would like to begin by acknowledging that I'm joining you from the unceded territory of the Lekwungen-speaking peoples, including the Songhees, Esquimalt, and Wasanic peoples. I also appreciate that there are those of you joining from elsewhere and consider the territories of the land in which you reside. Also, we are second-year med students and not doctors, not yet anyways. And so please consult with a healthcare provider if you or any others you know have any personal health-related concerns, especially related to the content of these lectures as well. We are also not experts in this topic, but we have done our best to research it and to present it to you in the best way that we can. Some things might be out of the scope of this lecture, but we will do our best to answer any questions that you have and to make this a good and informative lecture for you. Some final few notes before we get started. You can ask questions anytime in the chat box. They will be reviewed by the Mini Med School team. Most will be saved till the end, but if there's something you'd like clarified at the moment, feel free to ask the question. We've already mentioned turning off your cameras. A copy of these slides and the recording will be available on Dr. Gair's website. So you guys will get full access to all the information I have here, as well as my links and sources. We will have a 10-minute break in the middle of the lecture, so hopefully around 9:30, and then you can take a 10-minute break. And we're aiming to talk for about an hour and leaves about 15 minutes for questions at the end. And just an extra special note here, I'd like to give credit for this lecture to Dr. Clarissa Wallace, who is a clinical endocrinologist in Vancouver and a professor for UBC Medicine. And she gave me a lot of great knowledge and insight when I was researching this topic. So grateful for her contribution. But first, we are going to kick things off straight away with a poll question, and it kind of relates to why I didn't explain Ozempic a lot at the start of the lecture. So the question is, what is Ozempic? And I will start the poll now so you guys can answer. Is it a European car brand? B, last year's winner of The Voice, the popular TV show? C, the name for a baby ostrich? Or D, a medication used for the treatment of diabetes? And let me go check out this poll. All right, we're getting some really good responses. All right, don't need to spend too much time on there. I haven't fooled anyone. So yeah, you all got it right. Ozempic is a medication for diabetes. So thankfully, pretty much all of you know exactly what it already is. And I sort of threw this in to have a bit of fun at the brand names of drugs that the drug companies come up with, not the scientists or us healthcare professionals. All Ozempic is just a brand name. And I found this cartoon uh, very pertinent to make that point as well. So here's our outline for today. First, we are going to talk about some of the current events relating to Ozempic and some background and history of how it was first made and how it's been used. Then we're going to learn more about the physiology of diabetes and obesity, which are the two chronic diseases that Ozempic and its analogs is currently indicated in the treatment of. Then we're going to take a break, and after the break, we're going to talk through all the treatment options for both diabetes and obesity. As you will come to see, there's some mild overlap between them, but then we're also going to talk about some things that are distinct, such as surgical options and some common medications, including, of course, the exact mechanism of action for Ozempic, so you all will know how it works. And lastly, we are going to briefly cover what the current clinical advice is for the use of Ozempic and other GLP-1 agonists, and leave you all with some final thoughts. So without further ado, let's get started. So as mentioned, Ozempic is the brand name for a drug called semaglutide. Semaglutide is from a class of medications called the GLP-1 receptor agonists or analogs. And all of these drugs end in "-ide" that you will see during this lecture. So we're going to talk in the next slide exactly what GLP-1 stands for and how this class of medications was first developed. Ozempic is manufactured by the company Novo Nordisk, which you may have heard of in the news from their very catchy advertisements. And so this is a screenshot from one of them here, where you may have heard them say, "Oh, oh, 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 Ozempic." I think it's also a really good time now to remind you that I'm not being paid by them whatsoever, and I have no stake in Ozempic at all. So this is not being funded by them. Ozempic comes in the form of a subcutaneous injectable pre-filled pen that is administered once a week for patients taking it. It has a variety of dosages, and currently in Canada, it is only approved for the treatment of patients with type 2 diabetes. For people in BC, it is covered by MSP for diabetes once a patient has already trialed some other medications first, like metformin, for at least 3 months. Now, it was approved in Canada all the way back in January of 2018, but there have been a lot of recent news stories and social media hype that have gotten it lots of attention. Just for some more background on what Ozempic is, we need to look at something in the body called incretins. Incretins are naturally occurring hormones in our body that are released after meals. They're released by cells in our digestive system and pancreas. So this whole system here. They function to stimulate insulin in response to food and in a phenomenon known as the incretin effect. And they do this in a very potent way compared to other ways our body has to induce insulin release. So some examples of these incretin hormones that are found in our body include things like glucagon, like peptide 1, and gastric inhibitory peptide. And as you can probably guess, Ozempic is related to the glucagon-like peptide 1 hormone. So what Ozempic is it's a synthetic analog of this naturally occurring hormone in our body. However, contrary to the current attention you've seen Ozempic get, these drugs are not new. GLP-1 was first discovered in the human body and in scientific research in the 1980s and 90s, where some of the initial research was done in these creatures called glia monsters. And so GLP-1 was actually first synthesized from the venom of these glia monsters and was produced and sold as exenatide, which was first approved by the FDA in 2005 for treating type 2 diabetes. So that's where they got the drug, is they extracted it from these glia monsters, which I found very interesting and very weird as well. So over the course of the next few decades, a lot of companies out there continue to invest in the research and development of these drugs, increasing their dose and their potency. And that resulted in the manufacture of Ozempic, which was first approved by the FDA in 2017 for the treatment of type 2 diabetes. There have been many drugs that have since followed, including Wegovy, which you may have also heard of, which all Wegovy is actually just a higher dose of Ozempic or semaglutide, and that has been approved by the FDA for the treatment of obesity directly. However, the obesity has to be accompanied by what's called a weight-related condition or comorbidity, like high blood pressure, high cholesterol, or even type 2 diabetes. Even more recently, there are new drugs out there like Mounjaro and Zepbound, which are more fun words to say, made from a GLP-1 analog called tirzepatide. And so while all these drugs are pretty similar and they're all based on the GLP-1 format, it's really important to know that drugs can only be approved in Health Canada for sort of the indication that they've been tested for. So when the companies are first doing the research on these drugs, they're testing them on patients with type 2 diabetes for their treatment. And so for something like Ozempic, it's still in Canada, not currently approved for the treatment of obesity, unlike Wegovy. And it's not approved in the United States for that reason either. However, as we will see later on in this lecture, that may change in the coming years with growing interest and investment in this field. So, as mentioned, these drugs, despite them being old news, have become a recent cultural phenomenon in the medical field. And they've been featured many, many times in the news and on TV. These two articles here were just from this past year, highlighting some of the important current events around Ozempic. The first and arguably most important thing that has come up a lot in the news is Ozempic being used off-label for weight loss as a treatment for people without diabetes, but with some form of obesity. This popularity has been compounded by a lot of celebrities in the media talking about their experience using these drugs. Most recently, Oprah, and even Elon Musk was tweeting about it, and it was getting a lot of popularity in that way. And so I'm going to talk a lot about these other current event issues next. So the increasing attention and off-label use of Ozempic has led to a dramatic shortage of Ozempic, particularly here in BC, with the province having to take some important steps to regulate its use and sale. The most famous situation of note was a case where a doctor in Texas with a Nova Scotia medical license wrote 17,000 Ozempic prescriptions in 3 months to be filled by mail to American patients. And so that was quite the scandal. And the majority of these prescriptions were filled at 2 BC online pharmacies, and they cost much less here, so that's why they were exporting them. However, the province took action and they prohibited the sale of Ozempic via mail on April 19th, 2023. And so before that period of time, we had, according to them, shipped out about 30,000 doses of Ozempic down to the States. And since then, it has been just over 100. So it had a dramatic impact. And the doctor in Texas has since had his license suspended from being in Canada. However, we've seen here from some more recent news stories, as late as October, we still appear to be dealing with some supply chain issues for the supply of Ozempic. Another recent story in the news has been the increased instances of side effects from these medications that Health Canada has warned about, such as some nausea, vomiting, stomach pain, even pancreatitis, and even more serious ones that have been investigated by UBC recently, such as stomach paralysis and the risks of bowel obstruction. Furthermore, when people stop the medications, it's known that they tend to regain this weight. And this yo-yo pattern of weight loss can be very dangerous for the risk of complications from the drugs and the development of things like cardiovascular disease. Talking more about current events, there is a whole issue of fat phobia and weight stigma in our society that has a lot of people feeling a lot of different ways when it comes to the topic of Ozempic being used as a weight loss drug. On one hand, there are people who think that Ozempic should be used as a weight loss treatment as a primary concern. And the fact that people are hesitant to do so is because there's a societal stigma that obesity is not a disease and rather something that can be changed solely with behavioral changes. On the other hand, there are many people who claim that treating people's obesity with Ozempic, when it's for weight loss, actually reinforces this stigma that being overweight is not acceptable in society. And so, as you can imagine, this whole issue here is a very complicated issue. It is something we are going to talk about more in this lecture as well. On the bright side, though, with all the new attention and investment in these GLP-1 drugs, more research is coming out with the potential for these medications to be used to treat other conditions such as alcohol use disorder, to reduce cravings, polycystic ovary syndrome, PCOS, for helping reduce insulin resistance, to helping treat some cardiovascular issues as well. And even we're learning about it in school just this week on the potential use for GLP-1s to treat non-alcoholic fatty liver disease. So on reading more about this topic and sort of to wrap up the current events section, I came across this quote that I really resonated with, and I think represents the goal of this talk in helping to address what we talked about in regards to weight stigma. It's from a psychologist and associate professor of family medicine at Dalhousie University. His name is Michael Vallis. And when talking about Ozempic, he said that we need to reframe obesity as a chronic disease where it's not about weight, it's about health. So as we'll come to see, obesity is not something that diet and exercise can fix for everyone. Additionally, the weight itself is not the issue, since, as we know, people come in all shapes and sizes, and it's about the health complications that can develop because of it that we are worried about. So that is our flyover of all the current events and issues surrounding Ozempic. But now I want to switch gears to provide a bit more information on diabetes and obesity, which are the treatment targets for GLP-1 agonists like semaglutide. And hopefully that will give you all a bit more of an understanding for how and why these things work the way they do. I just quickly see a note here in the chat. I want to make sure. Oh, that was just some personal notes. That's all good. All right. Let's get into it. So first, we're going to start by talking about type 2 diabetes, which is a very common chronic health condition that even some of you may have. In fact, it is estimated that 31% of British Columbians live with diabetes or prediabetes. Now, that includes undiagnosed people, since only about 11% of British Columbians are diagnosed. As you may or may not know, type 2 diabetes is a chronic disease in which you have too much sugar or glucose in your blood, and this is because our body cannot regulate these levels properly. This is due to impairments in the secretion or response to insulin from our pancreas, and that is normally supposed to regulate our blood sugar levels. And so I've kind of depicted the whole process here, where we sort of have a meal intake, we get high blood sugar, and that stimulates our pancreas to produce insulin, which causes our liver to convert it into a storage form of glucose called glycogen, and that helps to lower our blood sugar levels. So that's the normal response. However, in diabetes, that can become dysregulated. Now, there are not a lot of there are not a lot of identifiable direct causes of type 2 diabetes, but as you know, there are many risk factors. A lot of people associate type 2 diabetes as a lifestyle disease characterized by poor diet and lack of exercise. However, it actually has a high genetic potential for causation, similar and actually superior to the genetic link for some people to develop type 1 diabetes. And that has been demonstrated in these types of investigations called identical twin studies. As mentioned, there are some other forms of diabetes, such as type 1 and gestational diabetes. However, we're going to be focusing on type 2 for this talk as it is by far and away the most common. So when you have type 2 diabetes, sugar stays in the blood rather than entering the body's cells to be used for energy, and this is what causes your high blood sugar. Now, these symptoms of high blood sugar include feeling very thirsty or very hungry. You may also urinate more than usual, have blurry vision, or lose weight without trying. There are also some symptoms of low blood sugar to know about. However, those are less likely that you'll experience those unless you take something like insulin to help treat diabetes. Diabetes is diagnosed with a series of blood tests, and screening for all adults begins in your 40s and occurs at least every 3 years. So you may have heard of an A1C test or a fasting glucose test, and those are what physicians use to diagnose diabetes. However, even with treatment over time, these levels of high blood sugar can actually cause damage to many parts of your body, most prominently in the small blood vessels of your body, such as in your eyes, your kidneys, and even in your nerves and your fingers and toes. And it can also lead to complications in even the larger blood vessels in the body, putting you at risk of like heart attack and stroke. And so after the break, we're going to talk more about what these treatment options are to help keep the blood sugar levels low. Now, here's just a diagram of the vascular complications of high blood sugars that I was talking about, how they can lead to things like atherosclerosis or fat buildup in your arteries, this thing called nephropathy, which affects your kidneys and how they become very leaky and you can lose proteins in your urine, and retinopathy in your eyes. And so that's how people with diabetes can get blurry vision or actually even lose their eyesight. And so that's because these cells within the inside of your blood vessels called the endothelium is being damaged by these levels of high blood sugar. So it's really important to keep those down when treating diabetes. So that's our quick conversation about diabetes. Now I want to move into obesity and to sort of check back in with you guys and see how you're still doing. We're going to start with a poll. So I want you to all guess what percentage of people in 2018 in Canada were classified as obese. And we are going to launch the poll there. And we're going to get into it more exactly what the diagnostic criteria for obesity is, but this is just a general question about the prevalence of obesity that you think there is. All right, we've got some great responses here. I'm going to end the poll there. Great, and share the results. So as you can see, there's a wide variety of responses here, with some saying 50 and 45%, but the majority of people thinking it's about the 25 to 35% range of people in Canada being diagnosed with obesity. So getting back to the questions, and so here's the answer. So I'd say probably the majority of you were right in about that, the middle range. And so according to Stats Canada in 2018, 26.8% of the population were classified as obese, and that corresponded to about 7.3 million adults. As you can see here, though, when we talk about obesity, that's one thing, but we also have a significant amount of the population that's also classified as overweight. And so here's some more information from Stats Canada. Um, they found that even in the 65 years or older category, when you look at the ranges, they have about 27% that classify as obese. But adding in the percentage of the population that's overweight, you can see that almost 2/3 of people are actually meet this sort of overweight to obese category. So there is quite a significant amount of the population that falls into those population level categories. But what exactly does that mean, and how does a person fall into one? And we're going to talk about that more now. So, like diabetes, obesity is a chronic disease characterized by excessive adipose tissue in your body that causes an impairment to health. And that's a really important point. In BC, our population prevalence of obesity is a bit lower at about 23%. And so it's about 1 in 5. Now, as mentioned, obesity is defined at the population level by something called body mass index. And that's a number that's obtained by taking your weight and dividing it by your height squared. So they have it in kilograms per meter squared here. And you can see how things fall into these categories that range from being underweight to a normal range from about 18 to 25, overweight from 25 to 30, and then anything above 30 falls into the obese category, and they have a different list of stratification there. So similar to diabetes, there are actually no defined causes of obesity, but there are a lot of risk factors that can lead to its development. And that includes genetics and some lifestyle factors. So for genetics, you may have heard things like your metabolism or or the metabolic rate at which you can process energy. So depending on your personal genetics, you may be predisposed to more weight gain than others. When talking about lifestyle, there are the obvious physical factors you've heard of, like diet and exercise, but also some psychological factors to mention, since people struggling with depression or PTSD can have some difficulties with food and overeating. And so when talking about the causes of obesity, it's important to address these factors as well. So when it comes to obesity, you can get symptoms directly from the adiposity and increased weight, and that includes things like asthma, obstructive sleep apnea, osteoarthritis, or like chronic pain in your back and your legs. And then directly from the increased adiposity, obesity increases the risk of serious chronic illnesses such as heart disease, cancer, stroke, diabetes, non-alcoholic fatty liver disease, among others. And that's more related to the effects that increased adipose or fat tissue in your body has on creating this chronic inflammatory state in your body that you're constantly having to fight against. And so at the general population level, we've seen that obesity is defined based on BMI, the body mass index. However, at an individual level, it's really important that the assessment and diagnosis of obesity is individualized to include other factors such as waist circumference, skin caliper readings that you may have seen here, as well as an evaluation of some of the risk factors. And this is really important to do because BMI is very notorious to both underestimate and overestimate health risks in certain adults. So, for example, BMI is known to overestimate being obese and having just your BMI be related to that is often overestimated in highly muscular adults and athletes as well. So for personal example, I'm a former athlete. I've played rugby for a number of years at quite a high level, and so I'm about 6'2", 220 pounds. And when you calculate that into the BMI scale, that puts me at about 29 on the BMI scale. So according to those guidelines, I'd be obese, or I'd be very close to being obese. However, if you were to take all the other measurements and to look at my body on an individual level, that would not be the case for me. So it would be inappropriate to stratify me in that way. BMI can also be underestimated in some adults over the age of 65 if they lose some muscle mass. So just because you might fall into the normal range, you may actually have increased adipose tissue that is not appropriate for your current status in your body. So it's important to not get hung up on what those numbers are for just the BMI, and to consider things holistically. So just as before, we will get into treatment in the next section for obesity, but I want to also talk about how we assess and stage obesity when it comes to having treatment options. So the important thing to note about this slide is that obesity is not only characterized by increased adipose tissue, but also the fact that it impairs health. And so that means that not all obese patients actually require treatment. And so while we always want to encourage a healthy lifestyle of low caloric intake and exercise, there are these genetic and social factors that can make losing weight quite difficult. So to address this, Obesity Canada recommends the use of this tool called the Edmonton Obesity Staging System. And so that helps determine the severity of obesity and to guide clinical decision-making in how we initiate treatment, taking into consideration how things affect health from the medical side of things, how things are affecting the mental status of the patient, and how it affects their functional limitations of their everyday as well. So even though a person may fall into the over 30 category of obesity, if they're in sort of this subclinical stage where there aren't any effects on their health or their functional status, they actually don't require treatment. And so this option for helping to stage obesity is quite important. And that also relates back to what we were talking at the start of the lecture about the theme of weight bias and stigma that a lot of people with obesity do experience. So, as we mentioned, obesity is a medical condition that's caused by a lot of factors, but people often think that individuals living with obesity are personally responsible for their weight because they eat too much or don't exercise enough. And this belief is the fundamental driver of weight bias, weight stigma, and discrimination. And so it's been reported by Obesity Canada, and it's known that stigma contributes to an increased morbidity and mortality independent of weight or body mass index on people with diabetes. So it doesn't matter if they're sort of higher in the overweight category or over 40 for BMI, those that report experiencing stigma actually have a higher morbidity and mortality. And so this means that we as healthcare professionals and all of us as a society have a duty to treat these people with the same care and compassion that we treat other people living with chronic disease. And so from a healthcare perspective, this means that doctors should practice asking for permission when talking about weight, using private areas for things like weighing patients and doing waist circumference measurements. They should also ensure that their physical spaces are inclusive and adjusted for size when needed, such as having larger blood pressure cuffs for some individuals. And lastly, when we get into treatment, the recommendations for individualized care to address obesity need to be individualized and way much more than simply just eating less and moving more. And so having that individualized approach for treating obesity is going to be vital for improving health outcomes in this population. Great, so now it's time for a break. We have about 10 minutes that we're gonna leave you guys to, so I'll see you back at 9:45. If you haven't already, feel free to fill out our pre-lecture survey. Um, and yeah, thank you all for your attention. I know that was a lot to get through in the first bit, but we have a bit of a shorter section for the last part as well, and then we can get into answering all of your questions. So that's great, and we'll see you at 9:45 after the break. Take care. All right, hello everyone, and welcome back. Hope you've all had a good break. So now we're going to move on to the last part of the lecture, and as I mentioned, it should just be a bit quicker, but we're going to talk more about Ozempic directly and get into some of the treatment options. So let me get my slides working again. Good. So, as mentioned, I want to focus on all the various treatment options that exist for both diabetes and obesity. But I also want to talk about Ozempic, and it's going to sort of be a big picture idea here, and you're going to be able to see how it fits into the treatment of both type 2 diabetes and obesity as well. So in this section, talking about treatment options, we're going to talk about three main groups of treatments. So first, we have lifestyle interventions. And since there's some overlap here for the treatment of obesity and diabetes, we're going to talk about them together. Next, we have some different options for medications, which there's some overlap, but some distinct treatments from obesity and other ones for diabetes. And lastly, we are going to briefly cover some of the surgical options for treatment, but that largely falls under the realm of treatment for obesity. So, as mentioned, these treatment options may not apply to everyone, and adults living with obesity should receive individualized care plans that address their root causes of obesity. And so they can be provided with support for behavioral change, but as well as having these options for other therapies like medications and surgical interventions, because sometimes the lifestyle interventions just aren't enough, and it's okay that some people may need these other forms of treatment. All this information has been sourced from our national guidelines from Obesity Canada, Diabetes Canada, and then there's some further information from HealthLink BC, which is a great resource for BC-specific information. So starting first with the lifestyle interventions, before we get back into things, I just want to check in with all of you guys as well to bring you all back in after the break. So the question is, how many minutes of weekly physical activity is recommended for all adults? And so this information is based on the Canadian 24-hour movement guidelines for adults, and that does not mean 24 hours of activity. So I'll start the poll now. And so your options are, and remember, this is how many minutes or hours of weekly physical activity. So how much you get in a week. So is that 2.5 hours per week, 3 hours per week, 4 hours per week, or 5 hours per week? And so this corresponds to that many minutes per week of cumulative physical activity that is recommended in Canada. So give you a chance to lock in those answers. Great to see so many of you guys already back here with us. Great. I'll give it 10 more seconds and then we'll close the poll there. Okay, we're gonna end the poll there and share the results with you all. So it looks like the majority of you guys said 180 minutes per week or 3 hours per week. There were some of you that said some higher, and then 5 of you said that it was 150 minutes per week. So getting to the answers. So the answer is actually, as 5 of you said, only 2.5 hours per week. And that works out to only 30 minutes per day. And so there were a few of you that said it was some higher ones. So hopefully, if this is new information for you, I hope you all find it helpful that the health recommendation guidelines for physical activity is only 150 minutes per week or just 30 minutes a day, 5 days a week. And so these are the standard guidelines not only for the treatment of diabetes and obesity, but also just general health maintenance for all adults from 18 all the way up to 100. And so the type of exercise, we will get into more as well. But yeah, just that is sort of the cumulative amount of time they recommend that you exercise. So, as mentioned, here are going to be the lifestyle intervention recommendations in the treatment of obesity to help achieve weight loss, but also in type 2 diabetes, which helps improves our body's ability to control blood sugars. So the first option being nutrition. And instead of dieting or just eating less, Obesity Canada recommends that for people struggling with reduced caloric intake, that they be counseled by a registered dietitian for the introduction of something called uh, the medical nutrition therapy approach. And that is an individualized approach that is taken on by a registered dietitian to help achieve a caloric deficit in a way that um, encourages some healthy habits of eating and also long-term um, uh, commitment to this dietary approach. Then there's physical activity that we talked about. And so it's that 30 minutes a day of activity. And what they recommend in national guidelines that this physical activity be moderate to vigorous exercise. And how they define moderate is as doing an activity that you can still talk with, but you can't sing. So they call it the talk test. So you want to be slightly out of breath, but say you're going for a brisk walk and can still have a conversation with the person next to you. That's great. However, they want it to be intense enough that you couldn't like sing a song or do anything like that. And so just like a brisk walk or, gardening can even be something that a lot of people find physically intense. And so that is going to be your personalized recommendation for you. And it's known too that not only does physical activity help reduce weight, but even if weight does not change, because say you build muscle and you're compensating for that, um, it can help people also improve their glucose control because their muscles in their body are better able to use sugar and to take it up from the bloodstream. It helps to reduce your blood pressure, increase energy, helps with sleep. It's just like catch all, one of the best things that you can do for your body. So physical activity is highly recommended. When it comes to other lifestyle interventions, there is obviously smoking cessation and helping to reduce alcohol consumption. And these two are really important for helping to reduce the risk of developing complications from obesity and diabetes that we talked about earlier, like cardiovascular disease and stroke. They also mentioned that it's important to manage other comorbidities that a person might have, like high blood pressure or high fats in your blood, like cholesterol. These can have some approaches as well, like helping to reduce stress or reducing fat intake in your diet. However, these can also be managed with some medications as well that may be important to take. And then, as we talked about earlier, there are some psychological conditions to consider, like depression and PTSD, that can contribute to the development of diabetes and obesity. And so it's important that these be screened for and addressed to address the direct root of the cause. And that can be in some interventions like cognitive behavioral therapy can help address those. And so catch all, the goal for all these lifestyle interventions is to achieve a sustained 5 to 10% loss in weight over time, and then also improved glycemic control or control of your blood sugars. And your doctors can check up on you in this with doing frequent blood tests. So if you have diabetes, you might know that you have to get some blood tests every 3 to 6 months. And so that's how they are able to determine what your level of glycemic control is. And so here's some more reference for you on lifestyle interventions that I won't go into more, but here is some of the dietary intake recommendations from Canada's Food Guide. And here's more information on the physical activity recommendations from the 24-hour movement guidelines. And I've linked these at the end of the presentation for your reference. For now, though, we're going to move into talking about the medications used for the treatment of obesity. Now, there are various options available in Canada that some of you may or may not have heard of them, but we're just going to mention some of the most common ones. So the first one is a drug called orlistat, which is a gastrointestinal lipase or fat enzyme inhibitor that inhibits the enzymes that break down fat in your gut. So the fats that we eat in our diet need to be broken down into small pieces before we absorb them. So if we block this enzyme using orlistat, this leads to the excretion of these fats undigested in our bowel movements. So it has some modest evidence for helping to reduce weight. However, it's known to have some unpleasant side effects, such as bloating and fecal incontinence, as well as some oily spotting. The next drug is called bupropion naltrexone, or by its brand name Contrave. And this is more of a psychological medication that helps act on both the gut and the brain to reduce cravings for food. And so on their own, bupropion is an antidepressant, and naltrexone is something called an opioid antagonist medication. But they've been in this combination therapy. This is the only indication for them is that they are used to help reduce cravings and to treat obesity. And it has been shown to help reduce weight in some individuals. And lastly, we have our GLP-1 agonists that we're going to talk about more. But before things like Ozempic and Wegovy became a thing, there still is a drug called liraglutide, which, as you can imagine, is another GLP-1 agonist used for the treatment of obesity, but that exists as a daily subcutaneous injection, whereas these other options are a weekly injection. And so just a note from Obesity Canada, these types of medications can be used for individuals that have a body mass index of greater than 30 or a BMI greater than 27 with weight-related complications such as hypertension and high cholesterol. The really important point to note here is that they're only indicated for the use in combination with the lifestyle interventions we talked about earlier. So it's very important that these things are only shown to be effective when a person is still able to make changes to both their physical activity and their caloric intake, or how many calories they're eating. So that's it for the drugs for treating obesity. Now getting into some of the diabetes medications. So this is a very scary summary slide of all the different types of diabetes meds that are out there and exist. And so I just wanted to show you this slide so you can appreciate the scope of options that physicians have in the treatment for diabetes. However, we're just going to focus on these ones because these are going to be the most common ones that you may have seen before. So the first one is metformin, which is a very common medication that you may have heard of and is often the first line for treatment for people with diabetes to help improve their glucose control. The next one is a class of medications called SGLT2 inhibitors. And this is a bit of a newer class, but they are becoming a lot more common because they're very effective and they all end in flozin. And so that's kind of the relation here. And then as you can see here, we have the incretins, including GLP-1 agonists, but also another group called DPP-4 inhibitors. And so they're kind of related in the incretin class, but we'll get into those in a little bit. So starting first with metformin, the important part of its mechanism is that it works inside the cells in the liver in structures called the mitochondria. So there's this really complex process here where it inhibits some of the mitochondrial complexes, but overall, it results in the reduction of the liver's ability to make its own glucose, which is an important function of what it does to help control these levels. So by inhibiting this process of gluconeogenesis, this helps our body to regulate its glucose levels to keep the blood sugars down. So that's all I want to talk about for metformin. I won't get into this big process here. So when it comes to the SGLT2 inhibitors, the mechanism here is a bit more straightforward. So they work in the kidneys in these structures here called nephrons, and this is like the functional unit of your kidney. And so what the normal process is, what happens in our kidneys, is that here, a lot of the glucose in our blood is just naturally filtered out. And then in these tubes here, it is reabsorbed back into our body. And that is the normal process of what it's supposed to do. However, in diabetes, when these glucose levels are super high, it would be helpful to get rid of some of the excess glucose. And so that's what these drugs do here, is that they inhibit the channels that reabsorb glucose from our urine. And so the result is that we actually pee out more sugar than normal, and that helps remove it from our body. And so that is how these two common medications work that you may have heard about, metformin and the SGLT2 inhibitors. We're going to get more into Ozempic and stuff, but especially given these two options and the list that you saw earlier, you may be wondering how on earth we choose what to give. And so another really scary slide, but just to show you guys is that these are the recommendations from Diabetes Canada of how we figure out what the additional treatments are for diabetes. We often always start with either metformin or insulin, but we have a variety of different algorithms and processes to figure out what types of medications you should be on. And so that's for your reference if you want to look at it later. But in talking about the medications, I want to finally describe to you all more about Ozempic and the other GLP-1 agonists. So Ozempic or semaglutide, as you already know now, is a synthetic analog of GLP-1, which is one of the natural incretin hormones in our body. And so these hormones are stimulated by food and released after meals by the cells in our digestive system. And they function, as we mentioned, to stimulate insulin in response to food, which can be helpful for treating diabetes. But it's also known that they have a variety of other functions. And so those include reducing the rate that our stomach empties so we can feel fuller for longer. They help to reduce the amount of sugar that our liver makes, kind of like metformin. And then they also help suppress appetite in our brain. And so those are going to be some of the major functions of these GLP-1s as well. And then as you can see from this diagram here, we have options like GIP and GLP-1 being released after the ingestion of food. However, they are also inactivated by an enzyme called DPP4. So that's actually another target that scientists have found research for, is that if they inhibit that enzyme that breaks those down, they can find a way to naturally increase the levels of functional incretins in our body. So when we give a drug like semaglutide, we're giving GLP-1 that's like at a higher level than our body would normally experience. Giving a DPP4 inhibitor can slightly raise those because it's only the amount of GLP-1 that's available in our body. And so here's some more diagrams from that. But the big picture here, and this is probably the slide I want you to look at, is that there are sort of four primary functions of Ozempic, and that includes the decreased appetite, reduced glucose output from our liver, increasing insulin secretion, and helping to reduce gastric emptying. And so now you can kind of see how Ozempic was sort of first investigated for treating diabetes, but then it has become very effective because of its slowing of gastric emptying and decreasing appetite for helping to treat obesity. And so that's how they've been studied and investigated for. The other important point to note here on this side is that there is a dose-response relationship to GLP-1 that our body has. So with the lower levels of GLP-1 here, you can see you get some of that increased insulin secretion that's helpful for treating diabetes. But as they found more research doing it, they found that the larger doses tended to be more effective for treating obesity by causing weight loss. However, they also found that as you increase that dose too high, you can get these unpleasant and even harmful side effects like nausea, vomiting, abdominal pain, stomach paralysis, all those things. So the important point here is that it's always important to be managed and monitored by a physician when taking these drugs, and not to just sort of be taking them on your own, because the dose needs to be right for you. Otherwise, it can cause some of these complications. And so the last of the treatment options I want to quickly touch on is bariatric or weight loss surgeries. And so for a long time, bariatric surgery has been the cornerstone for treatment for people living with severe obesity and its related complications, and it has been a very effective but often last resort procedure. And while it's been shown to result from anywhere between 20 to 40% weight loss in some people, it has also been shown that some people can still put back on all that weight after these interventions. So it's not a permanent solution either. And so according to Obesity Canada, bariatric surgery can be considered for people with severe obesity, so having a BMI above 35 with certain comorbidities, or even having a BMI over 40. And so this treatment option is often reserved for people who have already attempted the lifestyle options and some of the medications. And there are a few different procedures that are currently performed in Canada. And so that includes things like a gastric sleeve surgery, where they take out a portion of your stomach to make it smaller, something called a gastric bypass surgery, where they actually decrease the size of your stomach and divert it directly into your intestines, or something called a duodenal switch, which is kind of another version of that. All very complicated things. However, when I was speaking to Dr. Clarissa Wallace, when I was first creating this presentation, she said that these procedures can have quite long wait times, and they are surgical procedures, so they have risks, and they're not meant for everyone. Even though a lot of people do live a lot longer with these surgeries. So the big question here is now, how do these surgeries compare with current GLP-1 treatment options like Wegovy for treating obesity? So we don't have that answer yet. But certainly with the increased popularity of these drugs for treating obesity and weight loss, it's something that's going to be a huge area of research going forward. And so that is all for the physiology and the understanding of how Ozempic works and how it relates to diabetes and obesity. I just want to leave you all with some final few notes on what the current clinical advice is for Ozempic. So the reality of the situation is that while Ozempic is not currently approved for treating obesity by Health Canada, since it's only approved to treat diabetes, it is still being used off-label for the treatment of obesity. And it's interesting because Health Canada approved Wegovy, which is the option that does treat obesity, way back in 2021. And as we've seen, Wegovy is just a higher dose of semaglutide in an injectable pen. But since Health Canada can really only approve the medications for the purpose in which they were researched, them changing how Ozempic is indicated is not likely to change in the short term. However, with more research and things over the years, that may change for Ozempic. And then as soon as that research comes out that it is safe and effective for these people, then that may lead to its approval. Wegovy is interesting because while it's been approved in Canada since 2021, it's never been sold in Canada because there's such a dramatic shortage of it being produced in the United States, and it hasn't even made it across the border for that reason. So that's why a lot of people are turning to Ozempic to sort of fill that gap, even though it's not indicated for it. So it's important to know that even for those people that drugs like Ozempic would help, it's not for everyone. As mentioned, there are some significant side effects that we mentioned already, like the nausea, vomiting, and stomach paralysis, as well as some absolute contraindications, so you cannot take it. And that includes having a history of thyroid cancer, being pregnant or breastfeeding, or being under the age of 18. And so, as mentioned too, similar to the other medications for obesity, it must be used in conjunction with the lifestyle interventions. So it is not a quick fix by any means. And that's kind of been indicated in a lot of health research and the news article as well, from testimonials from patients. And so drugs like semaglutide are also just indicated for long-term use. So as mentioned, short-term use to lose a few pounds or kickstart your weight loss journey is not appropriate and can even be dangerous for these risks of weight cycling that we mentioned. And so for those people that are not obese but want to lose a few pounds, this drug is not for you. And that's even the case even more because these are the populations in which the drug wasn't studied. So when they were doing all this health research to get approval from Health Canada, they were testing in people with obesity and type 2 diabetes that it would help. So if you don't fall into that category, we're not really aware of what these side effects are and could be, but very likely the dose is going to be a lot higher or too much for these people, and that can contribute to these poor outcomes and side effects. And the last thing here too that's important to note is that weight stigma still affects a lot of people, um, both in the stigma that they need to take the medication in order to achieve this, or that they may be perceived as being lazy. And as we've seen, is that diet and exercise is not a fix all for everyone, and there may be some people that do require these medications to achieve that. And so at the end of the lecture, I just wanted to bring back this quote here at the end to remind you all of our societal role in helping to reduce weight bias and our ongoing goal to reframe obesity as a chronic disease where it's not about weight, it's about health. So these are my references, and these are the more helpful resources for you that you can check back in when we post the PDF online. These are the ones from Canada's Food Guide and the 24-hour movement guidelines. I've also included a great podcast here on Ozempic that was recently on CBC if you want to listen to it. And then here is the link for the lecture recordings as well. And so that is it for this talk. We only have one more talk remaining next Saturday where my colleague Derek will be talking to you all about artificial intelligence in healthcare, which, similar to Ozempic, is a really hot topic current event going on. And I'm really excited to tune into his lecture as well. And so I hope to see you all there for that. So thank you all for your time and attention. We have some time now for some questions. We'll start with the ones in the chat first, and then we'll get to some of the other ones. And then afterwards, I can share the post-lecture survey for you all that I would encourage you to fill out as well. But yeah, I'm happy now to take any and all questions that you guys have. But thank you very much for your attention. Okay, I'm not seeing, yeah, some very nice comments. Thank you guys so much. I'm glad it was very informative. This was also helpful for my knowledge and my learning because I found I learned a whole lot of things as I was researching for this. You hear the Health Canada recommendations about how you're not supposed to prescribe these things as well. However, there's a lot more research that has to go into these things. And as we've seen, they can be helpful for people with obesity. However, it's really, really important, as mentioned, to always talk to your healthcare provider and your doctor if these types of medications might be right for you, and to be monitored by a doctor as well. Can you explain more about stomach paralysis? Yeah, I can try my best to do that. So when I was talking about it earlier, when it came to the significant complications that had been investigated, there was a research study that came out of UBC that found that on an epidemiological level, there were a lot of people that were experiencing these poor side effects. And that included by sort of slowing gastric emptying. And the thing that Ozempic does is it after a meal, you want to take some time to process your meal and stuff at the physiological level. So when our body normally produces GLP-1, it just helps to slow that process down. So the contractions of your stomach that helps to sort of churn the food up to help digest it and then to pass it into your small intestine to be absorbed, that slows down a bit. And now you can imagine that if you take a drug that is like far and away above what your body is used to, those the contractions of your stomach, and your stomach being a muscle, can actually become dysregulated and slow down to a point where it appears like it's not even moving. And so that is sort of a phenomenon like stomach paralysis. I'm not too sure anymore about what sort of the emergent treatment options are for something like stomach paralysis. I imagine it's something that we can I'm able to look up more and to share with you as well. But I'd say probably the important point to know is that the stomach is a muscle and has these circular muscles and the longitudinal muscles along your stomach, and it helps to churn your food. Whereas if you take a drug that helps slow that down, which is too high of a dose, or not right for that person, that can cause those muscular contractions to slow down and even stop. And so that's not going to be good, especially to help keep the food moving through your body and to absorb more nutrients. And yeah, that's probably the best answer I can give. I know we have some other experts in the chat as well that might be able to chime in, but yeah. And another nice note here is that someone will be sharing the information with other people. That is fantastic, and we really, really appreciate it. This is all sort of, as much as it's for us and the benefit that we get out of being able to practice giving presentations and to research these topics for you guys. We also hope that you guys learn something from these lectures as well and get a lot out of it. So it's really it's really great to hear that you guys can get something out of it and share it with your friends and family as well. And feel free to share the link as well to see these lectures online and on YouTube. And if you guys do want to do that as well, you can fill out the pre-lecture survey before you watch the other lectures as well. As mentioned, we have like 4 other ones that are currently posted there. I can actually go back so you can kind of see what the options are. I know they're a bit blurred out, but we have given talks this year on the new Canadian alcohol use guidelines, on how to access a family doctor in BC, on skin, some common conditions and concerns, depression in the elderly, and now on Ozempic. And then so you can fill out some post-lecture surveys for all those as well, and that really goes a long way for our education and to helping improve these lectures for the future. Oh, great. Well, if there are no more questions, I won't, keep you all here too much longer. You guys can all get a start on the rest of your day. I think Dr. Gair has maybe posted something. Oh, for the YouTube channel. Great. And that was how you can access all the lectures. I'll just share the last slide with you guys as well. So just before you go and go on with the rest of your day as well, if you would be able to, I would greatly appreciate your ability to fill out our post-lecture survey for this lecture. And so you can find it there. I will also post it in the chat for you all. Let me just make sure I can get that link up. Gotta navigate a bit here. Oh, that's not the same one. You guys will also all be getting an email with this link as well afterwards. So I'm just having trouble. Copy. There we go. Yeah, so as you can see in the chat, that is the post-lecture survey for this lecture. So if you have about 5 minutes, if you'd be able to fill that out, we'd really appreciate it. And as mentioned, you will all get an email with that as well. Great. So if that is all, I will let you go. I just want to say thank you again all for your attention and participation in this lecture. This is my last lecture that I'm giving as part of the mini med school series. And so for the past three that I've done, just want to say thank you very much for this opportunity. And, we hope to see you at our next talk and any of the future talks in the mini med school series with Dr. Gair.